So in this presentation, I want us to take a different view of COVID-19. Of course, a lot has already been presented, a lot has already been said in the media. We will take a different approach to make you understand some of the preventive measures that have been put in place to try and control the pandemic. So I'll try to keep jargon to a minimum in this presentation so that you may appreciate and get a solid conceptual framework of COVID-19. COVID-19 is caused by a virus known as COVID-19 virus, but what you may not know officially, the name of the virus is SARS-CoV-2, right? SARS-CoV-2, right? This is severe acute respiratory syndrome coronavirus 2. Okay, so the 2, of course, is to distinguish this current outbreak from the virus responsible for the 2002-2003 SARS outbreak. The reason why it's called corona is that if you look at the virus under an electron microscope, it has spikes, right? It has these spikes on its surface, which gives it the appearance of a halo, right? Hence corona, right? So the word corona means crown in Latin, right? So the virus has a crown-like appearance, hence corona. The other thing to note is the virus belongs to a large family of viruses, amongst which of course includes the 2002-2003 SARS, and another virus called the MERS, right? The Middle East Respiratory Syndrome, right? Which was responsible for an outbreak of respiratory illness in 2012. The virus is, of course, a respiratory virus which causes respiratory illness primarily, right? So the virus colonizes the upper respiratory mucosa, where it can cause upper respiratory symptoms such as cough, sore throat, and a mild fever. What really now causes death, what kills people, is the virus has a high affinity for a specialized type of cell in the lung alveoli, right? And this cell is called the type 2, right? The type 2 pneumocyte, right? So this cell is found right in the alveoli. That's the alveoli right here, where gas exchange occurs. These cells, the type 2 pneumocytes, have on them a receptor, right? A receptor called an angiotensin converting enzyme 2, right? It's actually an enzyme which in this case acts as a receptor, right? What is it receiving? It's receiving the virus. So the virus binds to this receptor, and that's how it gains access into this type 2 pneumocytes. And since the virus requires human cells to replicate, it binds and then enters the cell, replicates, and damages the cell that way. When damage occurs, of course, the body then responds naturally by producing inflammation, right? Which is the body's response to injury. And this inflammation is characterized by a release of a cocktail of chemicals, which include, but it's not limited to, the interleukins, right? So with interleukin 1, there's interleukin 6, right? And tumor necrosis factor alpha, right? So these are the chemicals that would then orchestrate other cellular activities that then subsequently lead to damage of the lung. Acute inflammation also is characterized or is accompanied by the recruitment of inflammatory cells, and one of them, of course, is the neutrophil, which releases reactive oxygen species. So eventually what you get within the alveoli is you get dead cells, right? The cells die. You get dead viruses, right? You get debris, neutrophils. You get also macrophages, and we call this process consolidation, right? You have to know that I'm oversimplifying. We call this process consolidation, and when this happens, the patient has developed pneumonia, right? Pneumonia. So unfortunately, it doesn't end there, right? So it doesn't end there in the sense that this very same process continues until eventually the patient would develop what is known as acute respiratory distress syndrome, right? Acute respiratory distress syndrome, or ARDS, right? So ARDS is characterized by fluid in the alveoli in the lung, both within the alveoli and interstitially. And of course, when this happens now, it becomes very difficult for the patient to breathe. At this point, it's no longer just a mild illness. About 10 to 20% of patients who get the infection and who are admitted would reach this stage of pneumonia. The other thing to note is acute respiratory distress syndrome makes it very difficult for gas exchange or gaseous exchange to occur in the alveoli, right? And at this point, the patient becomes hypoxic, and the work of breathing increases until the patient tires, which means they can't breathe on their own, right? They, at this point, may require the assistance of a ventilator, right? And you have to understand also that even with a ventilator, because of the compromised lung tissue, gas exchange is still suboptimal, right? So patients die because of multi-organ system failure, which means multiple organs fail as a result of respiratory failure and associated hypoxia. I think by now, with all that has been shared in the media, you all know now that asymptomatic transmission is possible. The incubation period of this virus is estimated by the World Health Organization to be anywhere between 2 to 14 days, right? And the reason why I have this normal distribution here is you have to note that the reason why we quarantine people for 14 days is because of this incubation period, right? So what this means is if a patient doesn't show symptoms within the first 14 days, they are unlikely to show symptoms, right? Remember that I'm saying unlikely. It doesn't mean that they won't show symptoms, okay? Because there are, of course, outliers, right? Those are freaks of nature who will show symptoms as early as day 1, right? And others will show symptoms after the 14th day, right? As late as day 24 or even 27, right? There have been patients who have shown symptoms after 27 days after exposure. So we are just saying the 14 days allows us to get the majority of cases, right? But still, with the 14 days, we still miss up to 5% of potential cases because there will always be these extreme cases, right? 14 days actually is the upper limit of this range, right? So the median here is around somewhere around 8 days, okay? Right, the next one is what is the case fatality rate? The percentage of cases that result in death, right? So cases that result in death. So we are looking at that proportion, right? So the WHO had estimated early in January 2020 that at that time the case fatality for COVID-19 was 2%, right? It was 2% back then. But if you look at the numbers now, the case fatality is about 6.87%, right? So this is, of course, the WHO number, right? So this will be the world average. You will note also that case fatality or the fatality rate can change as the virus mutates. It can change as case management changes, as we get to understand the virus better. And it can also change based on resources, right? You'll see also that it's different from country to country. Right now, if you look at the statistics, in Botswana, for instance, the case fatality is around 4%, right? Or 4.5%, somewhere there. And the case fatality in Italy, for instance, is 13.5%, right? But the world average is around 6.87% currently. Let us compare the case fatality of the current outbreak with other outbreaks, right? And see where the current outbreak stands in terms of fatality. The case fatality for the 2002 SARS, right? SARS 2002 was 10%, right? Which means that 10% of cases died. Case fatality for MERS, the Middle East Respiratory Syndrome, 2012, right, was 34%. was calculated to be 34%. The 1918 Spanish flu case fatality, right? The famous 1918 Spanish flu case fatality was around 10%. And the case fatality for measles, the reason why I put measles there is measles is one of the most infectious conditions there is. So the case fatality for measles pre-vaccine, right, before the vaccine, was 30%, right? This is pre-vaccine. Right, so the next thing that I want us to discuss is what is known as the basic reproduction number, which is one of the most important parts of this discussion, because if you understand the theory behind the basic reproduction number, you'll also understand the preventive or protective measures that have been put in place to control the outbreak, right? So what is the basic reproduction number? So the basic reproduction number, or R naught, is basically an average, right, of the expected number of secondary cases that can be produced by a single infection in a completely susceptible population, right? So to put this simply, it's the number of individuals that an infected person will transmit the disease to, right? The beauty of this number is that it's not static, right? Just like the case fatality, it's not a fixed number. It will change depending on what? On our behavior, right? So our behavior directly influences, right? This is the big part in terms of controlling the pandemic. Our behavior directly influences R naught, right? So it's directly influenced by our behavior. So I will explain how this works shortly, right? So, but the R naught for COVID-19 has been estimated to be anywhere between 2 to 3, which simply means that one person can infect 2 people. So if we model it mathematically, right, let's use 2, right, as the R naught. It means that one person can, on average, infect 2 other people, right? If we allow that person to roam freely in the community, right? They can potentially, remember we are dealing with averages here, right? Nothing is static, right? Nothing is written in stone, so to speak. We are dealing with averages. We are modeling reality, okay? So one person can infect two people, right? And those 2 people can infect 2 other people, okay? Can infect 2 other people. And these 4 can infect 2, right? 2 other people of their own, right? So I think you get the idea, right? And this 8 will infect 2 of their own, right? So in modeling this, we see that we start with 1, we get 2, we get 4, we get 8, and I think you can you can continue with the series here. So the next one will be 16, 32, 64, right? And so forth. So you can see that this is an exponential growth of numbers, right? And this is where R naught is important. And the beauty of it, like I said, is that R naught is not a static number, right? It changes, right? We can actually change it from 2 to 1 or to less than 1. But ideally what we want for the pandemic to wane out, to end, so that we don't get new cases, is for R naught, if R naught is less than 1, right? This is the situation that we want, right? Right now, R naught, if R naught is 2, we'll get an exponential rise, right? This is the situation where R naught is 2. But if we get R naught to be less than 1, right? Instead of getting an exponential growth, we'll get a decay, right? We'll get 0 new cases. So this is the situation where R naught is less than 1. Of course, if R naught remains 1, then the numbers will more or less remain the same if R naught is 1, okay? So your role in this is the R naught depends on 3 things. One of the things that R naught depends on is the duration of infectiousness of the condition, the virus. The other thing is the average time of contact between a susceptible individual and an infected individual, right? Someone who is not yet infected and someone who is infected, right? The average time of contact. And the third thing is the probability of infection given contact between someone who is not yet infected and someone who is infected. What's the probability that an infected person will pass the virus to an uninfected person? These are the three factors that R naught depends on. So just for comparison, let us look at the basic reproduction number of common conditions, right? Common viruses. The basic reproduction number of the common flu, right? The seasonal flu is 1.3, okay? The SARS, 2002 SARS, the reproduction number was 2.0, right? Or 2. For the Spanish flu, 1918 Spanish flu, it was 2.0 also, right? For the smallpox, right? Smallpox reproduction number was 5, okay? Remember, smallpox was eradicated, okay? Declared eradicated in 1980 by the World Health Organization. So we have no cases of smallpox anywhere in the world. Smallpox is in the archives of history. Chickenpox reproduction number is 5. HIV, it's 6. And measles, remember I said measles is one of the most notoriously infectious conditions, and its R naught reflects that infectiousness. It has an R naught of 18, okay? So this simply means that one individual, right, pre-vaccine, one individual was capable, with measles, was capable of infecting 18 other people, right? 18, right? And those 18 would infect 18 and so forth. So you can see that an outbreak of measles pre-vaccine would have been devastating. Okay, so what does this mean for you? What does it have to do with you, right? Okay, so I said our role as the public is in determining, in getting R naught to be less than 1. And the way that we do that, to get it as close as possible to 0, so that we get 0 new infections, is to reduce the duration of infectiousness, right? And of course, the way for this first point, the way this will be done is through a vaccine. So a vaccine, it is estimated, or it is predicted that it won't be available until 2021, okay? So of course a vaccine will be helpful, but it won't be available until this time. And we are looking forward to the vaccine, notwithstanding, of course, anti-vaxxers out there and conspiracy theorists, but that's a discussion for another time. The second factor that R naught depends on is the average time of contact between someone who is not sick and someone who is sick. And how do we do that? Measures that have been put in place to reduce this time, right? Through quarantine, through self-isolation, right? And through curfews, right, that have been put in place by governments all over the world, right? So the other thing is to avoid crowds, right? And we know why this is important, because in crowds there's a high chance that the virus can spread, and also to avoid travel, right? So you can see that these measures that have been put by governments are not arbitrary, right? They are informed by epidemiological studies in the way that pandemics propagate, right? So these measures are backed by evidence. Okay, so the third factor that R naught depends on is the probability of infection given contact between a susceptible and an infected individual, right? So the way that you do this to reduce the probability of infection, if you come in contact with someone who is infected and you are not infected, is hand washing. In the absence of water and soap, you can use an alcohol-based hand sanitizer, preferably from Health First. Just a joke. You can also avoid touching the T-zone. The T-zone includes the eyes, the nose, and the mouth, right? Avoid touching these areas as much as possible. The next thing that you can do to reduce the probability of infection given contact is the use of masks. There is popularly known the N95 mask, surgical masks, or you can even make your own mask. Gloves that can be used, this can be used by healthcare workers, right, or those in the health fraternity who are handling patients. Okay, so this also reduces the probability of infection given contact. The other thing is to use gowns, right, and goggles to protect the eyes, right? Gloves, gowns, and goggles would usually be used by healthcare workers when they are handling patients, Right, so we have come to the end of this presentation. I hope this was useful in getting you to understand especially the preventive measures that have been put in place and where they come from and what informs them and why it's important that you as an individual in the public follow these instructions or follow these recommendations as much as possible. A lot of this depends on our behavior as a collective. Thank you for your time, and if you have any questions or comments, please post them below.